Hi, everyone. My name is Alex Bryant. I'm the managing director of the TomTom Foundation here in Charlottesville, Virginia. And on behalf of our board and our team, I welcome you and thank you for choosing to spend time with us today. We hope you're staying safe and well in this time of COVID and are honored that you could be with us this afternoon. Today is our fourth talk in our collaboration with the United Way of Greater Charlottesville called Exposed, the Inequities Revealed by COVID-19 and the Path to More Just Small Cities. Today's talk will explore issues around health and healthcare in college towns, specifically around the major cracks within our nation's healthcare system and the communities of color who have been disproportionately ravaged by the novel virus. It's hard to believe that anything was once in person, but I've been told that our original collaboration with United Way was an in-person series that would have brought United Way leaders together for a chance to share insights from across their communities. Today, these conversations could not be more important. We've worked over the past weeks with the United Way team to bring this conversation to an online audience. The silver lining here is that today's format is much broader and inclusive than it ever could have been in person. We have over 400 registrants experiencing exposed in cities from cities across the country. And of course, I'm pleased to see so many of my neighbors from my hometown of Charlottesville joining us today to engage in these critical conversations. For those that are new to TomTom, this is a core mission of ours: to connect leaders across sectors. Entrepreneurs, nonprofits, educators, artists, engaged citizens, all come together to focus on the future of our hometowns and to work collaboratively, as we're doing with United Way, to solve today's most urgent issues. We're so grateful for this partnership with United Way and the opportunity to host these dialogues. This series will continue for 3 more weeks, Wednesdays at 4 p.m., so I encourage you all to please visit tomtomfoundation.org to learn more. And if you've missed any of the past talks, I highly encourage you to watch them. They're all very, very interesting. And you can find all of those talks on our YouTube channel. One last thing to note, this program today is presented as a pay what you can. All donations received through this program will go to United Way's COVID Recovery and Resilience Fund, which supports community members experiencing economic impact resulting from the pandemic. And with that, I'm pleased to introduce you to Ravi Rispetta, the President and CEO of the United Way of Greater Charlottesville.
Alex, thank you so much for the introduction, and again, the partnership with TomTom. This has been a phenomenal effort between both organizations to get information out into the community and allow community members to have a platform for getting to know one another and sharing their perspectives and their experiences with each other. So as a community-based organization, we're committed to a strong, equitable community where every person thrives. And the United Way is really as valuable only as the positive impact we can have with our neighbors, both on a personal and even a structural level. In fact, our work is really defined by and judged on our ability to create strong, more equitable, and more resilient communities through our partnerships and programs such as this TomTom program series that works to expose the inequities in our community. And with COVID-19 exacerbating many of these inequities in communities of color, in a disproportionate way, especially in a healthcare system, it's important to have public and potentially uncomfortable conversations about the context of this and even the qualities of how we move forward. It's vital that we bring experts such as Dr. Michael Williams, that's here with us today, into these conversations to encourage different perspectives and grow from one another's diverse points of view. We're excited that you've joined us today, and we hope that you'll actively participate in the session and our remaining 4 and bring what you've learned and discuss here to your offices, your dinner tables, and even your social circles. Be a part of the movement and walk the walk with us and join us. So thank you again for taking the time out of your busy schedule. There's a couple logistics I'm going to run through today just so you are familiar with how the session's going to work. So today's session will be broken into 3 parts. First, Dr. Michael Williams will give you roughly a 25-minute presentation. We'll then send you into breakout rooms for about 15 minutes to discuss a few questions for conversation with other members of the community. And if you've not done so already, please enable the video and microphone icons in the top left corner of your screen so you're able to participate when the time comes. And we'll close out with a Q&A portion with our speaker where you can ask questions and get some insights into some of his experiences at the university. Please note that the chat function in the bottom right corner of the screen, we'll ask that you direct your questions there, as well as encourage you to interact with your fellow attendees there throughout the session. And if you don't mind, and if you haven't done so already, please put where you're dialing in today from so we can know if you're local or from outside our community. And with that, I'd like to welcome Michael Williams, Associate Chief Medical Officer for Clinical Integration, Associate Professor of Surgery at UVA Health Systems and Medical School, and just thank him for sharing his insights and his wisdom and his experience with us. So without further ado, Michael, I turn it over to you.
Thank you, Robbie, and thank you, Alex, and thank both the Tomtown Foundation as well as United Way of Greater Charlottesville for the opportunity to have this conversation with everyone today. I think we're going to have an important conversation, and I'm going to warn the participants that we're going to go to school a little bit. We're going to talk about some history, we're going to talk some civics, we're going to talk a little bit about geography. There'll be lots of maps to memorize, so pay close attention, take notes. We'll get into some discrimination discussion, ultimately winding our way down towards social determinants of health, and then their impact on equity, and how all of those things tie into both COVID and the university and Charlottesville's response to COVID. I promise you, you won't be disappointed. Without further ado there, perfect. All right, so as Robbie said, I am a surgeon and faculty and therefore an educator at the University of Virginia School of Medicine and Health System writ large. And as I mentioned earlier today, I'm going to take you on a bit of a journey through several domains that have nothing at all to do with healthcare, but I connect to them at the end of our conversation in a way that I think will make sense, and also maybe to some degree give you a sense of what we have to do as communities in general, but also specifically here in Charlottesville to really achieve health equity, which is the goal, and how COVID sort of exemplifies some of the gaps we have to close. So as you can see on the title slide, it's really going to be a longer conversation than COVID, but it's going to be a connection between the disease that happens to be, in this case, COVID, and communities in general. So how do we get here? I think all of you who are from Charlottesville or were paying attention a couple years ago, we're coming up on the anniversary of these individuals who shall otherwise remain nameless, although I think several of the ones pictured are in jail right now, who visited the university and brought with them a degree of transparency that we haven't seen in some while, but I'm going to try to convince you that part of how we got to where we are today is tied to the very belief system that these people were promulgating on that summer day in August 3 years ago. So here's your first geography quiz, and you don't have to answer it now, obviously, but do pay attention. The question is, what is this map depicting? And we'll get back to it, and there'll be a key at the end, so don't panic. But what is this map depicting, and roughly from whence did it come? So put that map in your mind, and the answer is not the USA. So let's just start with that. Okay, that's not the cheat sheet answer. But I want you to remember this map as we go through the next few, because they're, I think, very telling, and it connects us to how we get to this conversation of health equity and COVID response, not only here, but also across the nation. So this next map is self-explanatory and is the product of the Kaiser Family Foundation, which, if you're interested, has a whole host of information that's widely available on the web for free. And if you look at this map, you'll begin to see some patterns develop, I think. So obviously this one's labeled easily read, share of non-elderly population as a person of color by state. And you'll see that Virginia has more than a third of our residents, not necessarily citizens, but residents who are people of color as defined by themselves in the prior census. Now this is data that's now 6 years old, but that number has not gone down really anywhere in this country, so there's no reason to believe it's gone down in the United States. Well, that will be a more important conversation here in a slide or two. What I want to show you now is the eligibility of Medicaid map, if you will, by state in 2014. And 2014 is a pretty important benchmark for our conversation today. As many of you know, it was the year that the Affordable Care Act became, or otherwise known as Obamacare, became actually implemented law as opposed to having passed and being signed into law. So the law was passed before 2014, but it became law in the states that chose to expand, and this is what this map shows, in 2014. So it was the first chance that individual states had the ability to really impact their uninsured populations by providing coverage for them. And I think you'll begin to see some patterns here. The states in the Deep South, in the Central Plains, states on either coast, largely either already had expanded in the case of the District of Columbia, or had announced legislative plans to expand. And you'll note that Virginia is not one of them in 2014. And Tennessee had leaning no, because they had 10 care, which was sort of a version of Medicaid expansion that was already underway. And then you'll note that Arkansas was one of the earlier states in the Deep South to expand and sort of commit to that process of Medicaid expansion. So that's 2014, also from the Kaiser Family Foundation. And so we fast forward to now. This is the most recent data that was updated last week, actually, by Kaiser Family Foundation. And I've highlighted Virginia, obviously. And so we had expansion implemented on January 1st of 2019, although enrollment began in November of 2018. But I want to draw your attention once again to the map. And you'll see that all the northern states, so the original most of the original 13, plus a couple extras, all of the western coast states, all of the western central plain states, the mountain west states. But the holdouts remain the Deep South and much of the central plains. Fascinatingly enough, since this map in 2014, where you'll note Nebraska and Oklahoma were not expanding, very recently, in fact, Oklahoma this week passed a resolution during their election cycle that they would in fact expand Medicaid as well. So these two will become dark blue when their legislative sessions kick in the next election or the next legislative cycle for their respective states, probably calendar year 21. And so there'll be fewer orange states left in this map come this time next year for sure. So if you hadn't figured out what this first map I showed you in the red, gray, and blue, and what these intervening maps are, here's your answer. And if you look down here in the bottom left of the slide, you'll see that these are the Confederate States of America as they were self-described by those who sought quote-unquote independence from the United States. And so the pattern between the Confederate States depicted here and the states that have still not expanded and have resisted expansion of Medicaid, even though many of their peers, even one or two like Louisiana, Arkansas, and the Deep South have, is an important part of this conversation that ties into how we get to COVID and how we get to how the university and our community needs to respond and to make sure that health equity is achieved. I say this because health equity is many, many things, and we'll get into some of the details in a second, but it certainly is not free. And there's the old adage of someone's got to pay is no more true than in any space than healthcare. So this is another great example of a decision that is made by a local government that leads to this map, being what it is today. And so part of what we're here to talk about today is the fact that you really can't unpack the future of how we're going to achieve health equity here in Charlottesville, greater Charlottesville area, Albemarle, the Commonwealth, the country, without looking backward a fair piece to see that we got here kind of on purpose. So how do I make this connection between this map and health equity and the COVID response of the university and the health system in particular? Well, I do that because there's this wonderful thing called the social determinants of health that many of you who are on this call may be familiar with, but I have here on the right a partial bulleted list of many domains of non-clinical, non-healthcare related activity or subjects or topics that directly impact, and we're not still quite sure to what degree, individuals and therefore for communities. So if you just go to the cheat sheet diagram, which is the product of World Health Organization, you'll see that things like the neighborhood and the built environment, we'll skip over health and healthcare for now, economic stability, education, social and community context, all of these things are components of health equity and are described and defined as the social determinants of health. And if you look in the right hand, again, there are some specific bulleted lists. And I want to highlight a couple in particular, like transportation options, availability of community-based resources in support of community living and of opportunities for recreational and leisure time activities. That has to do with things like the built environment, walking spaces so that people can, in fact, walk for exercise as opposed to belonging to a gym necessarily. socioeconomic conditions like concentrated poverty and the stressful conditions that accompany it, and residential segregation. And I think it'll be a surprise to no one on this call that those two things go inextricably together and are going to feature pretty heavily in our conversation going forward. This also from Kaiser Family Foundation, and it's dated, but in their estimate, based on the work of Schrader et al. In 2007, healthcare, so the delivery of health services to an individual or a family, accounts for 10% of health and well-being and health outcomes. So how long one lives, how healthy one's life is that they live it, genetics, and therefore things that you really can't modify, maybe a third. I think that's probably in some serious debate now in literature. But you'll note that social and environmental factors and individual behavior are 60% in their metric. And I will tell you that there are those of us who believe that the healthcare piece is accurate at 10, but that genetics, individual behavior, and social factors are probably more like 60 to 70% social and environmental factors. And so your lived environment very much has to do with your clinical outcome and your life expectancy and your well-being. How do we connect that to Virginia? Well, this map is going to tie in the conversation about social determinants of health that we've just had and our environment and our community. So in this map, which is a map of food insecurity, and this is a recent map, as you can see from the Feed Virginia group, this map was created and generated in 2018, at the end of 2018, so it's fairly recent. And the colored boundaries identify the really massive areas that the various food banks listed in the table serve and cover. For those of you who aren't from here, you'll see that little orange, very, very orange dot is Charlottesville, the city of Charlottesville. And unfortunately, if you look over here in the key, you'll see that we're in the city of Charlottesville in a community that's got roughly 1/4 of individuals or families are food insecure. Now, you may ask, how do I connect food insecurity with COVID-19? Well, as I said earlier, the social determinants of health are pretty important for all of us. And so food insecurity is a good one to take us through. And part of our challenge, and there's some work that's been published in social media by one Brendan Novak, who is Chief of Staff to Delegate Adams in the state legislature here in Virginia, that pretty clearly shows how hard it is to walk to groceries by neighborhood. And it will surprise few of you that people of color, particularly if you are African American or Latinx, have a much greater distance to walk to a full service grocer to achieve groceries. There's a separate series of maps that he's done, and I don't know him, so I don't have permission to show you those maps, but please do search them up yourself. This shows the density of ethnicities in the different parts of the city of Charlottesville in that same map overlaid, and it turns out that if you are African descent or Latinx, the chances that you can walk to a grocery store within half a mile of your house are much, much lower than if you're white. How does that happen? Well, it isn't an accident. As the map of the Confederacy shows, there were deliberate decisions made 150, 200 years ago that are still playing out today. And so the next series of maps I'm going to take you through, or early conversation we're going to have, is the work of Jordy Yeager, who is seen here, and really highlights the incredible work that's happening locally at the at the Jefferson School for African American Heritage and the African American Heritage Center that's doing some tremendous scholarship on the local history here of Charlottesville, as well as Albemarle, which is very, very instructive as to how we get that orange dot that I showed in that prior map. So bear with me, and this is part of the history. Here are some original documents that Jordy found, and if you look very closely down here, it said, this is a covenant from a deed of sale to a parcel of land that is actually not too far from Fifth Street Station now, and it was called Woods Addition then in 1904. And if you look right here at the very bottom, it says the two covenants that were baked into the sale of this land had to do with the fact that they are not to be sold to Negroes. And so very deliberately, the landholder who was a family that was given that land as part of their birthright, if you will, and that's an important part of the conversation as well, was essentially trying to subdivide this for their own use and any future generations' use, but they made a covenant as part of the law, it's public policy, that says that they shall not sell that to Negroes. No matter who else were to buy it, it couldn't be sold to anybody who would be described as a Negro in 1904. So to give you a sense of where that is in modern Charlottesville, if you zoom in, I think I'm going to get it here. All right, so that's the 250 bypass, and you'll see 16th Street Northeast. So you get, for those of you from Charlottesville, you get a sense of where that is. And it's a nice part of town. It's got some very nice parcels on it still today. It's got easy access to 250, obviously, in the bypass, and therefore 29 north and south, and also easily access 64. So prime real estate that was told specifically to its succeeding owners that you can't sell it to a person who is described as Negro. So a little bit of the history of this particular lot. In 1904, 2 lots sold for $1,250, which is pretty big money, obviously, for 1904, or $312 each. In 1918, so 14 years later, the property had accrued value up to from $312. In 1907, one sold for $300, and then it was sold again in 1919 for $800. And you can see that as they begin to pass this forward, the family, that is the Woods family, sold one of the lots to Sally Stewart, who was daughter of Micajah Woods, for $1. And so a very expensive piece of property was sold for $1 to the family, which kept the covenant going, but also kept it in the family. And then eventually in 1914, Frank Lindsay, who ultimately ends up being, James Lindsay ends up being the original founder of the Daily Progress, founding editor, also sold it for much more than it had been bought and or sold back in 1904. And so as you go through this, you'll see that the accumulation of wealth per Jordy Yeager occurred through property ownership, and today these properties lots are worth between $268,000 and $4 million, and those lots alone, that's generational accumulated wealth within that family and within those families who owned it. Now, today, if you can afford it, you could be African American and buy that lot. You could be Latino, you could be Jewish, but for about 100 years, that wasn't the case. And so the ability to access all parts of town and therefore to access things like food easily was denied African Americans by covenant, by law, by policy, and that was enabled. So how do we tie this to COVID in the community? Well, this is from the CDC. This is, I think, 2 days ago. In fact, I stole this from the CDC. And as COVID began to bubble up in our community, I think people were beginning to realize that the language being used was that it was most deadly for people who have chronic conditions or have other medical comorbidities. Well, that's, in my mind, code for people who are lower income, African Americans, Latinx, white, rural folks. And as recently as you see here on July 17th of this year, the CDC added some specific diagnoses, and you'll see them listed: cancer, chronic kidney disease, COPD, immunocompromised states, including from solid organ transplantation, but also specifically HIV, obesity, serious heart conditions, sickle cell disease, which is a disease that only affects African Americans, and type 2 diabetes, which disproportionately, all these diseases, for those who didn't know, very disproportionately are prevalent in African Americans, as well as Latinx individuals, whether they're citizens or not. And so when I started hearing this speak about chronic conditions, my heart clenched, because based on my clinical experience, I knew what that meant. And what does that translate to for us here in the community? Well, here in Virginia, and we are no different here in Charlottesville, here are the cases reported across the Commonwealth as of two days ago. And this is from the VDH website. And you'll see that First of all, almost 23,000 cases have no race or ethnicity reported, so we don't really have great data for this. But we do know from the early map I showed you that in 2014, roughly a third of Virginians were people of color, as self-described, and that number is maybe a little bit higher now, but not much higher than that. And yet, of the cases that we have seen in the Commonwealth, 27,000 roughly are experienced by Latinx folks, 16.5 or so thousand by Blacks, and 2,000 or so, 3,000 from Asian or Pacific Islanders, and 21,000 cases among whites. So how does all this tie? Well, again, if you have limited access to land use that allows you to have access to easier access to walkable food, to green spaces, to public spaces, if you are denied by policy, if you're denied by covenant those accesses, then your health outcomes are affected. COVID is the most glaring, flashing red example we have right now. But I showed you that prior slide to make the case that what we're talking about both here in Charlottesville as well as across the Commonwealth is a disease that doesn't impact African Americans or Latinx or Asian and Pacific Islanders more or less, but it does impact people who are living at or close to poverty, who are the victims of generational racist policies and covenants that made them vulnerable, not because of their intrinsic ethnicity, but because of the lived experience and the context, because of the social determinants of health. And all of those things tie back to the Confederacy and the belief that whites were somehow superior and that African Americans at that time, but also eventually Jews and Latinx were inferior human beings. And a lot of the policies that we are seeing now and the conversations we're having with Black Lives Matter and other things are really tied back to that original map of the Confederacy. For us as a community to move forward, we have to know this history. We have to know these linkages so that we can't just say, well, if we just have more doctors or just more nurses here in Charlottesville or at the university, we just put more clinics in place, we're going to improve health equity or achieve health equity. I would submit to you, based on all these data that I've tried to connect and weave together for you today, it's actually not true. Right, for us to do this and what our task is as a university community and as a small city with a major university in it is to work together in partnership with groups like the United Way and TomTom and many others to understand this history and to know that to really improve these health outcomes, and COVID is no different than any other chronic condition, we have to know this history and we have to undo it deliberately. So my last slide before we do the breakouts, I hope I've convinced you that racist 19th and 20th century policies are having 21st century impacts, and COVID is the best example we can use right now. Non-health related policies like housing, zoning laws, food access are having health outcomes, health impacts on our communities. And these are not accidents. The Confederacy was not a mistake. They didn't slip into secession. It was deliberate and intentional. It was based on race. Ancient racism is very directly affecting the health and wellness of modern Charlottesvillians, and COVID is no exception. And in fact, is the sort of the whipping boy, if you will, for why we are seeing the disparate response that we have and different outcomes for COVID as we are across the country. And with that, I will end and open it up for the breakout sessions and take any questions you have. And please do enter them in the chat as Ollie mentioned earlier.
Great, Michael. Thank you so much for presenting today. It's really incredible to connect the history of our community with the health outcomes that we're seeing now. So a critical part of the idea behind this series is to provide you all with the opportunity to discuss these issues directly with other members of the community. So we'll now be sending you into breakout rooms with a few other members of the audience here today to reflect on the following 2 questions. Please consider any takeaways you'd like to share with those of us here today as you discuss these questions in your small groups, and we'll provide you the opportunity to do so in the chat when we reconvene. The 2 questions are, has the local healthcare system provided for your healthcare needs adequately, and what do you believe could be improved based on your lived experience? And number two, have you experienced disparities in your healthcare access based on where you live and or whether you have healthcare coverage? Please be reminded that in order for other members of your breakout to hear and see you, you must enable your video and microphone by clicking the icons in the left top corner of your screen. And bear with us for just a minute. It takes about 15 seconds to 30 seconds to get you into your breakout room. Once that's done, we'll bring you back and we'll do some Q&A and close out today with Dr. Michael Williams.
Great.
Great. So welcome back from your chat sessions. I'm hoping everybody had some good conversations around the topics that we brought up today. So now is a moment to kind of open it up for Q&A with Dr. Michael Williams. If you have questions for him about things that came up during your chat sessions or just in general about what he presented today, we'll have about a little under 15 minutes to go ahead and have those conversations. So if you want, there is a Q&A tab that you can put your questions into, or also just into the general chat. And maybe while people are thinking of their questions, Dr. Michael Williams, is there anything you might want to share just about UVA bringing students back that could impact our situation here locally with COVID that might be of interest to the audience today?
Sure. Thank you, Robbie. So yeah, I have several concerns that are not just my own, and it's not so much that the students themselves are going to become particularly ill with COVID. That will happen. In general, though, our student body at the university, as I think everyone knows, are generally speaking healthy, generally come from backgrounds that are stable and safe and are really not impacted materially by the SDOH I mentioned earlier in the talk. But that doesn't mean that they won't be carriers and spreaders of COVID. And certainly some of the behavior we saw at midsummer by people who looked like they probably were UVA students from across the green would suggest that there's going to be some behavioral choices people are going to make and may not make favorably. And the analogy I always use is that underage drinking is also illegal and against the law, but that happens all the time. Underage drinking at all is illegal, and it happens all the time, and it's a thing that we would expect college students to do. We don't tolerate it all that much, but it's a thing that happens. So the idea that we're going to have students come and be totally compliant with masks and what I refer to as life-saving separation from each other, I think is probably a bit naive. And the concern that I have really is not so much for the students who we can take care of, because most of them will just be told to stay home, whatever home is here in town. But the people they interact with, if they happen to be using university transportation and they're taking a bus, if they take the cat, if they go to a restaurant and are not and are served, if they come to the hospital and are not wearing a mask all the time or when they're eating, these are the kinds of interactions that students will bring many more of to the community. And the people who will be impacted are the ones who I mentioned earlier, who live in these food deserts, who many of whom work at UVA, frankly, who live in a situation where they are forced to take public transportation because they can't walk where they have to get, and are now interacting with students or someone who else interacts with students. I'm very concerned that the ripple effect that will be hard to document is what will be the biggest threat and challenge for the community because of the students, not on behalf of the students themselves.
That's very helpful. Yeah, thank you for sharing that out. It's obviously incredibly relevant right now. So we have a couple questions that have come up. So Miles Wood says, how can the healthcare system help address food deserts given its impact on overall health?
Well, that's a great question. It's near and dear to my heart, and I'm happy to say there's a group of nutritionists already at UVA who have begun to think about this. So there's a couple of things that we can do as a health system, although I would say that the university as a whole is probably the more likely agent in that space. One is we have a fair amount of food surplus, frankly, that doesn't normally, I would say normally, that doesn't get eaten. And so it ends up going to waste. And so there is a program that's in place now that redirects some of that surplus to local food banks. The other is that we can just, as a community benefit, as part of our nonprofit status, can redirect a portion of our food budget to the local food banks. The other thing that we can do is actually, as odd as this is going to sound, is we can actually take custom from the food banks. So if we are buying for the salad bar, and that the hospital has a big salad bar that's actually very expensive, it would be ideal in my mind if we were to purchase from local growers because that sustains the local economy and provides some stability for that sector of our community. But also helps the food banks keep their coffers full because they've got resources and revenue coming in. The university, as I think most of you know, is the biggest employer in the region and one of the biggest in the entire Commonwealth. So we have some leverage that we can bring to bear. The university also has the food service contract allow us to maybe apply some leverage to a large company like Morrison's to say that some fraction of your contract is going to have to go to support food banks, is going to have to go to looking at a place to invest in a fresh grocer or potentially supporting a local grocer or mom and pop or in a big city, a bodega style grocer with higher quality fresh fruits and vegetables and the kinds of things that you can get at Whole Foods for half your paycheck.
Absolutely. Another sort of food-related question. This is also from Miles Wood. How does Americans' relationship with food differ from other countries, and does that influence the underlying struggle we have here in the United States?
I think our relationship with food is historically different than other countries, but becoming increasingly overlapping. And unfortunately for the rest of the world, it's been pulled more our way. So the Western-style diet of low quality, high carbohydrate, high calorie diets has begun to sort of make its way across the globe because it's cheap to manufacture, it's cheap to produce, it's cheap to distribute. And sort of the drive-thruization of the American diet is one that is now beginning to crop up across the globe. And it is in part driving some of the diabetes that we're seeing all over the globe. And I will tell you that China has a massive problem with diabetes. They don't talk about it very much publicly, but it's a big, big problem for them because the large number of people who are low to no income in China live off of what we would call a low quality, high calorie diet. And the ease of access of things like fast food in China is increasing sort of by the year. We also have a rather odd relationship with food in that we waste a lot of food in this country, in part because for many, many of us, it's too easy to come by. And so part of that waste I was talking about in the previous answer has to do with the unconsumed but already prepared foods, and we just toss it. And so being more rigorous about how much we prepare, portion sizes are also something that we can control. And if you look at a dinner plate from my parents, I'm 53. If you go back to my parents, a dinner plate was, something about this big. A dinner plate that you can buy in any store now is about that big. Every commercial you'll see of anything other than gourmet food shows the plate covered in food, right? And so portion sizes have also grown along with our appetite for low-calorie, easy-to-access foods. That is not as true across the globe. Absolutely.
I'm curious. So I know one of the things we see at United Way with the client population we work with is a lack of primary care physician support, and ending up in a situation where the emergency room becomes sort of that first stop for care. How do you think the university is addressing that, and what proportion of patients coming through the door are kind of in that situation?
Yeah, so we are certainly very aware of the need for primary care, and part of our challenge had been Medicaid expansion or lack thereof until it became law a year ago and really became implemented a year ago. So we've seen a pretty significant growth in our newly insured patient populations, and all practices at UVA, certainly primary care practices, take Medicaid patients, as well as the uninsured. Now, the uninsured have very specific destinations within our health system. The University Medical Associates, or UMA, which has been in business for many, many years, and my good friend and colleague, Mona Carney, who some of you may know, has led that effort. And that's our residents and medical students are also central to that effort. It's not big enough, and the community that the need is bigger than we can really process through UMA, in part because the geography of Charlottesville is not make it easy to access UMA, right? It's hard to get parking. If you take a bus, it's multiple buses. It's kind of the same thing as that food map I showed or talked about a while ago. So we're kind of hard to get to. And one of the things that we've been looking at is where else in the region and where else in the city does UVA need to have a primary care footprint. So we've got stuff in the west of town in Crozet, we've got stuff in the city, obviously. Because Centera is not as enthusiastic about the Medicaid population or the uninsured, that book of business falls heavily to us, but not only to us. The free clinic has a tremendous need that it fills, as well as the Federally Qualified Health Center, which is a relatively recent development here in the city. So between us, we feel like we've got closer to the appropriate access. But the challenge really ends up being, if you're working 2 jobs or 3 jobs, when do you get to the doctor?
Right.
And the answer often is 11 o'clock at night when you've finished your last shift of your second job. And the only thing that's open is the ED.
Yeah.
So we're working on solutions in that same space.
Yeah, a lot of what we see is patients that haven't been able to get the primary care relationship in place, and so issues have been allowed to get, to a point where it's difficult to get the support you need at that point. So I appreciate that. Well, it looks like we don't have any more questions, so we'll go ahead and wrap up the session today. Dr. Michael Williams, it's been a pleasure to have you with us and sharing your insight and knowledge. We really appreciate your time and look forward to seeing you here in the community. If what was discussed here today resonated with you, please be reminded that all donations will go directly to the United Way's COVID Recovery and Resiliency Fund. As a result, the Charlottesville family struggling with the exact sorts of inequities this series explores. Funding will go to help those families rebuild with COVID. And thank you for taking the time to join us today. We hope to see you next week for our next program in the series titled Setting the Table, hosting a community table event for conversations around equity that Carolyn Emerson, our VP of Engagement, will be leading with a panel of participants from past community tables. So with that, we thank you again for being with us today, and we look forward to seeing you next week. Take care.
Thank you all. Bye.
Okay, take care.